Hello, thank you for attending this presentation on a health process improvement analysis project on NURS2 use in postoperative prostate resection patients in an extended recovery unit. My name is Rebecca Rowe. I am a DNP student at the University of North Georgia. So problem and background. The extended recovery nurses reported episodes of clinical decline in postoperative prostate resection patients with benign prostatic hyperplasia, or BPH, with lower urinary tract symptoms. And they asked me if there were ways to anticipate or predict these episodes. This occurred in a North Georgia community hospital that utilizes an extended recovery unit for patients that need extra monitoring before discharging home. This site was chosen to pilot postoperative care for this new innovative robotic ultrasound technique for prostate resection for non-cancer enlarged prostate with lower urinary tract symptoms in males, ages 51 to 90. The pilot was successful, and implementation and physician training culminated in a large population of men having this procedure over the traditional transurethral prostate resection, or TURP, as commonly known. The new procedure offers preservation of urinary and sexual function and provides a quality of life not known previously with the traditional TURP procedure. The nurses caring exclusively for these patients experienced patients having these random episodes of clinical decline and presented in various ways. Some males would faint, some would become diaphoretic, some would have severe nausea and hypotensive episodes, and some would have bradycardia, or some would have all the above. And nurses asked if there was a possible way to detect these signs earlier or to be able to predict them. So NURS2 was established in the ERU as a computerized documentation process, but it was not front-facing, and so therefore the nurses did not fully recognize this as an available tool for them for early detection. And during our discussions, it became clear that nurses had different ideas about what complete sets of vital signs were and did not always include temperature in each set of vital signs. The reason I bring up vital signs is because vital signs and NURS2 are closely integrated. You have to have the routine sets of vital signs to be able to calculate a NURS2 score, to be able to predict early clinical decline. And while NURS2 was established in the electronic medical record, we viewed open medical record reviews and chart audits and found that there was inconsistent use and limited use of NURS2 in the overall documentation. Hospital vital signs and ERU unit-based vital signs policies did not include NURS2 either, and frequency of vital signs, although stated, was not interpreted as intended. So clearly, nurses could not properly calculate NURS2 based on these findings. NURS2 started as NEWS, or NEWS, in 2007 by the Royal College of Physicians in the United Kingdom within the National Health System, because they were seeing multiple early warning system tools used, various communication language was detrimental to the patient safety efforts as people floated from one facility to another. Their language was not consistently understood or standardized. And in 2017, after evaluation of its worth and reliability, it was edited and reemerged as NURS2, is what we're using today. This new iteration uses thresholds and triggers to alert nursing staff in acute care settings to track and trend the NURS2 scores based on vital signs and their nursing assessments, which includes mental status or even supplemental oxygen use. The significance of the early detection of clinical decline is interesting. The RCP, or Royal College of Physicians, noted that clinical decline episodes can be detected approximately 7 hours before the actual event. And patients having surgery have a 25% chance of suffering some form of surgical complication, and the prostate resection procedure alone carries a 10% morbidity rate, meaning problems related to that treatment. Despite the latest technology for this prostate resection procedure, it remains very physically and clinically challenged in the patient population, and nurses must be meticulous in managing continuous bladder irrigation, managing bleeding, ensuring catheter traction is adequate to maintain pressure on the bladder neck, and the catheter remains patent without obstruction. So a little bit about the organization where this is occurring. It is Northside Hospital for Psych. It's an extended recovery unit. It's a community not-for-profit hospital in North Georgia. It provides over 20,000 surgical cases, over 26 operating rooms, and 2 endovascular hybrid suites annually. And it performs all surgical procedures with the exception of transplants and open heart surgery. The pilot hospital for innovative urological prostate resection procedures for males was a very low profile event because of the infrastructure and the ability to test out this procedure for its worth and to be able to train physicians on this new procedure. The extended recovery unit is an 18-bed facility caring for postoperative prostate resections and also a wide variety of other surgical procedures. It offers care for patients with an average stay under 24 hours, but longer than the average outpatient stay, and requires a little bit more stabilization before patients go home. The usual daytime nurse to patient ratio is 1 nurse to 4 patients. So the proposed solution for this project includes a clinical question. Does the use of NURS2 scoring system assist extended recovery unit nurses to improve early recognition of clinical decline and postoperative outcomes in prostate resection patients for benign prostatic hyperplasia with lower urinary tract symptoms, which is commonly called BPH with LUTS? The project purpose was to evaluate nurses' use of NURS2 before and after interventional education on NURS2 protocol for early detection of clinical deterioration and improved patient outcomes. And the aim of this quality improvement project was to determine whether educating ERU nurses on the benefits and proper use of NURS would increase the use of NURS2 scoring for earlier intervention and timely discharge home from ERU. The intended intervention consisted of education for ERU nurses that were consented to for this project. The education consisted of NURS2 early warning scoring system, the history of it, the benefits, rationale, and proper calculation. Hospital and ERU vital signs policies were also reviewed, and the proper use of NURS2 instruments, thresholds, and triggers, the documentation in electronic medical record and communication were also reviewed. So why was this intervention needed? Because it is not a mandated thing to use NURS, nor was it tied to the cadence or frequency of vital signs collection in the ERU, and there was inconsistent interpretation of what complete vital sign collection meant that we needed to make sure that everyone was on the same page and that there was a standardized use of NURS2 within policy and the frequency of vital sign collection. The evaluation plan consisted of these measurable outcomes. From baseline data to project results, improvements consisted of 4 observable variables with set expected outcomes for each. Observation 1 would have been the number of post-op BPH patients with documented NURS2 score, which would be expected at 100%. The NURS2 is, while not mandated, it is easily accessible now to be able to calculate with vital signs. The observation number 2 is the number of complete vital signs documented, and that would be based on the policy and the cadence and frequency of the expectations from admission to the extended recovery unit, and the expectation is 100%. The observation number 3 would be the number of NURS2 score calculations corresponding with those collected vital signs, and that was 85% expected. And observation number 4, the number of patients discharged home from ERU. And because of the clinical decline seen in this particular patient population, and because they had the ability to stay longer than 24 hours or be admitted to the hospital for further observation, the expectation for this uncertain observation would have been 75%. The IHI framework, called Framework for Safe, Reliable, and Effective Care, is mantra that all clinical nurses should ascribe to. It evolved from a time in healthcare history around 2017 where medical errors and preventable deaths in hospitals were occurring at an alarming rate. When patient safety is the outcome desired in nursing care within a healthcare system, the system must have equal parts of education and culture to help leadership support that culture and to promote a healthy and open environment for collaboration with team mentality and civility to ensure effective communication to the benefit of the patient. So the choice of this framework provides guidance for establishing a culture of safety where education is ongoing. Transparency and communication is utilized to support and report patient safety issues, and use of a familiar methodologies measures for quality improvement is used for improved patient outcomes. The instrument used here was granted permission by the RCP, and it shows you here that there's physiological parameters that are measured, with 0 score being the norms that are internationally recognized, and with scoring on either side, negative or positive results on those, or highs or lows based on those parameters. The interesting thing is that a temperature is necessary because of sepsis, consciousness, changes in mentality. Those are things that need to be done because of either neurodeficits or oxygenation deficiencies. Your pulse, your systolic blood pressure is the indicator of fight or flight, and air oxygen used for supplemental oxygenation is necessary also. And you're looking at different parameters here with positive or negative. And in a post-operative unit, when you see respiration rates falling below, that usually means some kind of medication or neurological symptomatology there. The other instrument that is important in this project has to do with the thresholds and triggers, and this helps nurses to understand how to communicate in a more efficient manner with providers. And one of the things, rapid response teams, and one of the things that we notice in the extended recovery unit is we have many new nurses that come to this unit and they're not really familiar with communicating directly with physicians. And so being able to use an SBAR tool or being able to use a tool such as this NURS2 threshold and trigger helps them determine what level of response is necessary, the clinical risk of whether it's low or high. When you get into the scoring systems of any individual parameter of a 3 or above would require more urgent response. Aggregate scores of all of those parameters listed in the tool above would show a low score, but anything that's individual that is a 3 or above, there's something going on with that patient physically or mentally. Aggregate scores of 5 or 6 are medium risk, and those are where you need to escalate some care, and if they get to an aggregate score of 7 or more, you strongly suspect sepsis in that patient. The data management plan was established for this project planning, population, time frame, and data. The data collected would have been electronic medical record review of those 4 observations we were looking at. We measured 100% want to measure 100% of all the prostate resection patient records 4 weeks prior to the intervention of education, and then 4 weeks post education. And we want to look at complete sets of vital signs, NURS2 use, NURS2 calculation, and discharge disposition. And the reason we put discharge disposition there is because the expectation of this patient is to go home from extended recovery and not be admitted to the hospital for further follow-up. The storage and protection of this data, it was kept secure and de-identified. The primary investigator had password-protected computer status, and it was established under data use agreement instructions that all of those guidelines would be followed during the project, and that data was to be destroyed in 3 years based on the DUA agreement. The data analysis, we use percentages for observations because we were doing the 100% of our chart audit review, and we had over 67% of our nurses consented for this project. We hope that that will be enough data collection and analysis to determine whether we saw an improvement or not. The dissemination would be results provided at unit-based QI boards for people to look at, and then also published in professional journals such as a perioperative journal or a perioperative conference. Thank you so much for listening to this presentation, and please look at the references for the sets of references used in this slide, and also slide presentation, and also the QR code for a full set of references used for the DMP project. Thank you so much.